Good evening, everyone. Welcome to our webinar on heartburn and acid reflux treatment. My name is Louise, and I'm hosting this session. I'm joined by our consultant gastroenterologist, Dr. Mayhead, and consultant general surgeon, Mr. Hamouda. This presentation will be followed by a question and answer session. If you'd like to ask a question after the presentation, please do so by using the Q&A icon, which is at the bottom of your screen. This can be done with or without providing your name. Please note this session is being recorded if you do give your name. If you'd like to book a consultation, we'll provide contact details at the end of this session. I'll now hand over to Dr. Mayhead, and you'll hear from me again shortly.
Well, good evening. My name's Phil Mayhead. I'm a consultant gastroenterologist at Benenden Hospital. I'm going to be doing the first part of this presentation on reflux and heartburn with regards to the diagnosis and investigations of heartburn, and then I will be handing over partway through the talk to Ahmed to take on talking about the treatment and of heartburn symptoms in the second part of this presentation. I can have the next slide, please, on. So as it says here, I'm a consultant gastroenterologist. I qualified in London, and I'm an accredited bowel cancer screener. I've been working at Benenden for around not far short of 2 years, and I take a number of interventional endoscopy procedures, including both upper and lower GI therapeutic endoscopy. Next slide, please. So very briefly, the history of reflux disease. It was first described, or the link between hiatus hernias, which obviously a lot of people are very familiar with these days, and the link between that and the symptoms of heartburn were first spotted in around about 100 years ago. And then it was a gastroenterologist about 10 years later attributed the reflux of gastric contents from that's related to stomach acid. And obviously our knowledge of this is far greater than it was, and this has evolved significantly over this time. Next slide, please. So reflux or gastroesophageal reflux, if you are looking this condition up online, you may see it written as GERD, as obviously American spelling is very ubiquitous. Gastroesophageal reflux from the UK, or gastroesophageal with an E, if you're looking at it from the United States. It is the same thing. It is a chronic condition, and it essentially relates to the passage of gastric contents up through the esophageal, up through the joint between the esophagus and the stomach into the esophagus due to poor closure of that sphincter and the junction, allowing gastric contents to wash up and down the esophagus. Next slide, please. So how common is this? Well, it's really common. In this part of in the Western world, about 10 to 20%. It's considered much rarer, nearer 5% in Asian countries. And it's considered clinically significant if symptoms are more than twice weekly. Obviously, how clinically significant depends on how bad it is for the individual, but from a sort of a clinical, from a scientific perspective, more than twice a week would be considered a significant amount of heartburn. And it typically presents with two things: the heartburn symptom, which is also the technical term is pyrosis, which is a burning sensation behind the breastbone, typically after a meal. And the regurgitation is the perception of gastric contents or reflux liquid with undigested food into the mouth or into the back of the throat, giving that bitter taste that people often describe, as well as obviously the contents in the mouth. Next slide, please. So what are the causes of reflux? Many reasons why you develop GERD. One of the big ones is smoking and being overweight. And if you develop a hiatus hernia, and obviously you wouldn't know that unless you had some investigations to find that out. Women will obviously talk bitterly about the reflux that develops during pregnancy. And very typically, you see it after a large meal and late at night. If you're eating late at night or having fatty or fried foods, fried and fatty foods tend to sit in the stomach, as I'm sure you're aware, for a lot longer than other meals. It's a lot longer. It takes a lot longer for the stomach to digest, and there's a much greater propensity for gastric contents to wash up and down the esophagus. And so the typical thing would be a Friday night out with a few drinks of alcohol, along with something fatty to eat as well, and then the next day paying the price with very significant heartburn and reflux. And certain other beverages such as coffee can be a problem, as can fizzy drinks as well. And stress is also well linked to reflux. So there are certain medications again that you may be taking for other things, such as benzodiazepines, the diazepams of this world. Calcium channel blockers again can cause. They are medicines that are often given for high blood pressure and occasionally heart rhythm problems. And then certain types of antidepressants and non-NSAIDs is things like Voltarol and ibuprofen. And all of these things can cause people to experience greater degrees of reflux. Next slide, please. So obviously those are very typical symptoms: the pyrosis, the heartburn, and the regurgitation are the two classic symptoms. But there are obviously less typical symptoms that can present because of reflux, and that can be dysphagia, which is the technical term for having difficulty swallowing. It's one of the alarm symptoms that people fear, is that there's a blockage in the esophagus, and chest pain. So people will often present to A&E with significant pain, chest pain across the chest, which can be indistinguishable and can be as severe as what you might perceive as angina. And so whilst it's clearly more important to investigate for heart conditions, very often it can be heartburn masquerading as angina. And then that water brash or that hypersalivation, that sensation when you get acid or a liquid into the back of the throat, you can get an uplift in the amount of saliva that's produced, and that can be another symptom. And often people when they come to clinic, they talk about feeling like there's a lump or a ball in the back of the throat. They feel like there is something there, and the technical term for that is globus. And it can be because it's the sensation of gastric contents just irritating the sphincter at the top of the esophagus here, and your brain tells you that there is like a ball or a lump in the back of the throat, and that can be part of the presentation of reflux. Nausea is another one, less common, but it is nonetheless a symptom of reflux. But there are obviously many other reasons why people feel nauseous. And dental issues. So people may go to their dentist, and their dentist says that their enamel in their teeth is damaged, and that can equally be because of gastric reflux. And then finally, a cough or hoarseness to the voice and wheezing can be a presentation of reflux. And often people will present sometimes to ear, nose, and throat surgeons because of symptoms in the back of the throat, as opposed to the heartburn that is more typical. And you can sometimes see redness and inflammation in the vocal cords because of gastric contents washing around the voice box. And next slide, please. So how do we evaluate for GORD? Well, probably the majority of people don't see a gastroenterologist. A lot of people remain in primary care with their GP. The diagnosis can be made most of the time, if the symptoms are very typical, with the typical triggers, by the GP, and giving medicines such as PPIs, the antacids, the omeprazoles, and the lansoprazole of this world, which I'm sure you will be familiar with, can be very effective, and up to 90%. 90% is quite generous. There are certain studies that say the response is a lot less than that. But in itself, it's not necessarily a diagnostic test, because there are more advanced tests of reflux problems which can demonstrate that you can still reflux despite having no symptoms, and reflux significantly to cause problems. And so this is why some people end up seeing a gastroenterologist to have further evaluation of their symptoms. So if there are potential alarm symptoms, or if there are risk factors for Barrett's esophagus, and I'll explain a little bit more about that in a minute as to what exactly that is in the next couple of slides. So next slide, please, Ollie. So a little bit of a busy slide, but the alarm features, the things that make my ears prick up when I'm talking to somebody about heartburn, is if the symptoms are occurring for the first time in somebody over the age of 60, if there's a suggestion that there's been any bleeding, If there are blood tests that suggest iron deficiency anemia, that implies that there's some, so that whilst there may be no overt gastrointestinal bleeding, there can be more slower bleeding that can make someone iron deficient, and that raises concern. Anorexia simply means you lose the ability to you lose your appetite, and you lose your willingness to eat. If there's unexplained weight loss, again, a concern. And I've mentioned here dysphagia and odynophagia. Dysphagia is difficulty in swallowing food, getting stuck. So when someone has that food bolus of that food, like some bread, and it's getting stuck, that is the sensation of dysphagia, the inability to get things down. And then odynophagia is pain on swallowing, and when it's painful as the food goes down, as that feeling of the sensation of it rubbing past something, and that can sometimes just be quite simply reflux, but it can sometimes present something more concerning, such as an esophageal ulcer, which obviously there are benign and more concerning variants of that. And if someone has persistent vomiting, then clearly, whilst reflux may be the cause, there may be very many other reasons as to why that is the case, and that would certainly merit further investigation. And certainly with regards to family history, if there was an upper gastrointestinal cancer in some first-degree relative, a parent or brother or sister, then that would certainly merit taking things a little further than just trying antacid medications and seeing how one goes. So moving on to things like risk factors for Barrett's esophagus. So Barrett's esophagus, I'll show you a picture of what Barrett's esophagus is in a slide or two's time. It's a consequence of reflux, and it occurs when there is a change in the lining of the esophagus to represent something that looks a little bit more like the stomach, and it can be of a variable length up the esophagus depending on, I guess, the length and severity of the history of reflux. And it doesn't necessarily, and the appearance of Barrett's doesn't necessarily correlate with the severity of reflux. You can have Barrett's esophagus with very minimal symptoms, or equally, you can have a lot of symptoms and very little findings. And so there is not necessarily a good correlation between what somebody experiences and what we necessarily see when we investigate. But Barrett's esophagus carries a greater risk of things like a risk of esophageal, a particular type of esophageal cancer, which is on the rise in the West, and esophageal adenocarcinoma, which tends to arise around the join between the esophagus and the stomach. And it is one of the main reasons why one of the key reasons why we often undertake endoscopy to either because there's a high index of suspicion, or indeed to put somebody's mind at rest. So the risk factors for Barrett's esophagus is where there is a duration of reflux of at least 5 or 10 years. If someone who has a first-degree relative with Barrett's esophagus or adenocarcinoma of the esophagus. Males over the age of 50 of Caucasian descent with a hiatus hernia who are overweight and smoke are all risk factors for Barrett's esophagus. And again, nocturnal reflux, people who wake at night on a persistent basis, there is a greater risk that someone will possibly have Barrett's esophagus. And so these are the sort of the indications why we might do more than just, or why your GP should refer, and why the NHS guidelines suggest referral for someone who has these additional symptoms over and above the straightforward ones. Next slide, please. So what do we do? What's the further evaluation? Well, generally all paths initially lead to an upper GI endoscopy. So with people who have untreated reflux, about 30% will have endoscopic esophagitis, will have changes in the esophagus. Therefore, that also means that 70% don't have anything. And it doesn't mean to say that they're not refluxing. It is just that there's not necessarily any endoscopic findings that one can see. The severity and the duration of symptoms correlates poorly with the severity of esophagitis. And obviously what you're looking for at an endoscopy is the endoscopic appearances. And you may wish to take biopsies to either confirm things like Barrett's esophagus or reflux esophagitis, or to evaluate ulcers, or indeed concerning things like cancer. For those people who haven't had an upper GI endoscopy, I will not try and pretend to say it is a straightforward procedure for everyone, because that's clearly not the case, but it is a really quick test to do, and it's a really safe test to do. It can be done on almost anyone, and it can be done either with somebody awake, it can be done with somebody awake with some throat spray to numb the back of the throat, and it can be done with somebody with sedation and throat spray to make the procedure much easier. But it is a very quick test. It only takes about 5 or 10 minutes, and a lot of information can be gathered from that. And obviously that information can be fed back on the day as to what has been seen. So it is generally the gatekeeper investigation when you're looking into things like Barrett's esophagus. If that confirms the diagnosis, then obviously it may well be lifestyle changes and other things that may well be advised. But if one is wanting to evaluate a little bit further, then one may wish to consider things like esophageal manometry and then what's called ambulatory pH testing. These are not done on everybody with reflux, but they are done in certain settings where one may wish to consider surgery, perhaps, or indeed if the diagnosis is in doubt, or if you're thinking that there might be another esophageal condition, because other things that can go wrong with the esophagus can be around motility disorders, where there is a problem with the mechanism that drives food and liquid from the mouth into the stomach. And so sometimes, whilst there may be a number of features of reflux, there is a need sometimes to do other investigations, and those tests can be tests where we refer people away for little tubes up the nose and into the tummy to measure the pressure and the acidity and how the swallow works, to try and understand more about what is going on. And that is important in part for diagnosis and also to guide treatments. And sometimes there is something called ambulatory pH monitoring, where there are devices that one can place in the esophagus, which can measure the acidity of liquid within the esophagus over 24, 48 hours. And at Benedon, we are in the process of launching a system to do that in people where the diagnosis perhaps is in doubt, where we can place a little device in the bottom of the esophagus using at an endoscopy session, where a little device sits there and it samples the esophageal liquid and contents, and sends data to a little data recorder that is worn by the individual, who can record their symptoms, and their symptoms can then be correlated with the finding of the little device in the esophagus, which ultimately falls off and passes through you. But it is a relatively new and safe way of trying to establish the diagnosis when the diagnosis is still in doubt. With regards to barium studies, I've put it in there because it is a test that is still used. Barium studies obviously were around an awful long time before endoscopy was. And barium studies are another way of demonstrating things like hiatus hernias, or they can demonstrate problems with blockages such as sort of strictures or narrowings because of a cancer or a benign stricture. Or they can be used sometimes to demonstrate that you are refluxing, but they're not a gold standard test, but they are a test that can be done to help aid the understanding of what is going on. Next slide, please. So just some pictures to break up some of the words. These are a couple of images of hiatus hernias, and this is, if you can see, the scope has been pushed down from the esophagus and into the stomach, and the endoscopist here has turned the scope back on itself. So the tip of the scope looks like a walking stick, and you're looking back up at the patient's head. And what you can see, don't know why I haven't got control of the screen, but I hope you can see that there is a tuft of tissue around the scope, with the sort of gap, and which is the diaphragm, which is the muscle that the large muscle that we use to breathe, which separates the chest from the abdomen. And there is an opening in the diaphragm in which the esophagus passes through to enter the stomach. And in a hiatus hernia, where part of the stomach is crept up into the chest cavity, it's the mechanism. You can see that the diaphragm squeezes the stomach a little bit further down, as you can see in both of these images here. Next slide, please. And just to make the point, just in an illustration, there are a number of different types of hiatus hernia that people can develop. And I think Ahmed will talk a little bit more about this later in terms of treatments, but you have where you have various hernias where the stomach slides through the esophagus. You get hernias where part of the stomach rolls alongside the esophagus, and you can get symptoms. You can get problems where the esophagus slides up and then rolls around, and a large part of the stomach ends up in the chest cavity. But all these can cause symptoms of reflux and swallowing difficulties. Next slide, please. So what can reflux do to your esophagus? So why is it important to evaluate for it? Well, it causes obviously a lot of symptoms. A lot of people have a lot of problems after eating, and it can be socially very embarrassing if you're getting quite significant heartburn. But in terms of the mischief that it can cause directly to the esophagus, it can cause reflux esophagitis, where you get damage and inflammation to the bottom of the esophagus, and this can ultimately lead to things like esophageal strictures, where the scarring from the repeated inflammation and healing in the esophagus from the repeated acid exposure causes the scar to heal with tightness and causes a stricture, which then obviously people start experiencing problems with swallowing. And then there is Barrett's esophagus as well, where you get the changes that I described before, and I'll show you a picture of that in a minute. And then there's esophageal cancer. And so sometimes my ENT colleagues will see people who have issues with their larynx, and you can get what's laryngopharyngeal reflux, where you can get that. You can get not necessarily get all the heartburn symptoms, but you get all the symptoms in the back of the throat. And there are other complications that can include things like aspiration pneumonia. So when people lie down in bed, sometimes if they've got a large hiatus hernia where it's very easy for contents to wash up and down, they can get that washing into their lungs and can cause chest infection. Next slide, please. The reflux esophagitis, very briefly, I won't go into the classification in any way, but clearly from grade A to grade D, the more inflammation you have, and I hope you can see the more interesting thing here with, I guess, is the pictures, where you can see the little red lines above in the esophagus, and that sort of what is more normal pale tissue, and you can get a lot more and more inflammation depending on how bad the esophagitis is. And next slide, please. And so the other major complications, so the Barrett's esophagus I've been on about a little bit is the slide on the left-hand side on this image. You can see that that sort of at the top of the image, you've got this normal pale esophageal mucosa, and then you've got this sort of finger of tissue that's poking up from the join between the stomach and the esophagus, and you get this sort of salmon pink tissue, which looks a little bit more like the stomach. And it is that is the Barrett's esophagus, which is a consequence of reflux and can be a risk factor for adenocarcinoma, for cancer of the esophagus. And in the middle is the cancer. That is perhaps a typical appearance of an esophageal cancer. And then on the right-hand side, this rather nasty, scarred-looking esophagus, and that little pinhole in the middle is what your esophagus can end up looking like from chronic reflux if it is just a benign inflammatory stricture that is scarred, and that is what one can end up with because of long-term reflux. The next slide, please. And I'm going to pass over here, Ahmed, to you to take on with regards to treatment.
Thank you, Phil. Thank you very much. My name is Ahmed Hamouda. I'm a consultant upper GI surgeon. I've been working at Benedin since 2013. I trained in the UK, but also did some of my training in Egypt, where I hold a professorship. And I have an interest in upper GI conditions as well as reflux. And I think the message from both myself and Phil today is that if you have reflux, which is a very common condition, do not suffer in silence. Go and see your GP, get some treatment, and it's likely that you will get something called a PPI, which is omeprazole, pantoprazole, esomeprazole, lansoprazole. All those medications are called PPIs. However, if that doesn't work and you continue to have breakthrough symptoms, then please come and see a specialist like myself and Phil, because as Phil said, there are things that we can do to further the diagnosis, make sure that we confirm that you've got reflux, look at your gullet, make sure there's nothing else untoward, and move forward with treatment. Now, broadly speaking, treatment is three things. So first of all, we're going to start off with dietary and lifestyle modification. And that's normally what everybody does at the very beginning. And we'll just go through a few slides describing that in a second. And then moving on from that, we'll go on to medications, which is the next stage after dietary and lifestyle modification. And if that doesn't work, then we are looking at potentially surgical solutions. So first of all, let's look at dietary and lifestyle modification. Now, as Phil alluded, there are a few risk factors and a few things that can cause reflux. We're trying to reverse those. So we're going to try and use gravity to help the acid that comes up into the gullet from the stomach to not stay in the gullet for too long and to flush down into the stomach. So you could try not lying down for 3 hours, propping up in bed, raising the pillow, lying on your left side to avoid acid going up into the gullet. Of course, losing weight helps, and try to avoid foods which result in your symptoms, as well as smoking, which is a risk for reflux. If you go on to the next slide. So the medications we're going to go on to and have a little chat about. Antacids can be things like Gaviscon and Reni that you buy over the counter and can be quite effective in helping your reflux if it's very mild. H2 receptor blockers were things that we used to do and use quite a while ago. They are still around because they tend to work in some patients. Some people have a tolerance to them more than proton pump inhibitors. Things like famotidine, cimetidine, and then you've got the PPIs, which are the proton pump inhibitors I just mentioned, omeprazole, lansoprazole, pantoprazole, etc. Prokinetics are drugs that increase the motility of your gullet, so try and push any acid that's in your gullet downwards into the stomach again. So the use of medication is very, very common. It's the first thing that will probably happen when you go and see your GP. And obviously, if it works, then great. But if it doesn't, I think you need to come and see us. Can we go on to the next one? So again, with food, obviously there are some people that have tolerance to certain types of foods, or certain foods will cause them reflux and other foods won't. So it's probably a trial and error, and you probably need to keep a food diary. But the worst culprits are, as Phil mentioned, fried food. You've got your peppers and chili powder. You've got fatty foodstuffs, which can cause meals to stay in your stomach for much longer and give you a higher incidence of reflux. Other foods that can cause it: citrus fruits, of course, acidic, chocolate, peppermint, fizzy drinks, and tomato-based sauces. Going on to the next slide. What can you do to help? So if you haven't already tried this and you don't know what helps you with reflux, then obviously these are good things to think about. Alkaline foods, for example, if you've got reflux and you haven't got your Gaviscon or Reni at hand, why don't you try a banana, see if that works? Try watermelon and lettuce. High fiber foods such as broccoli, green beans, and oatmeal can also help. Going on to the next one. So we've now explored the first two stages, which is dietary lifestyle modification. Try that, hasn't worked. Gone on to medication. Tried that, hasn't worked. A lot of people will then come through to us, the specialists, to look at your gullet, do some tests. Obviously, if Phil does an OGD and then moves on to a pH manometry and a Bravo capsule, where he measures the amount of acid that comes up into the gullet and gives me a score, sometimes called the Demeester score. And that score says, well, actually, there's an excessive amount of acid coming up into the gullet over a 48-hour period of time when the test is being performed, then we probably are going to be heading towards a surgical solution. And the commonest and most classic surgical solution that we have is an operation called a Nissen fundoplication. First performed by Rudolf Nissen in 1955. It's also called the gastroplication. And essentially, very simply, it is the floppy bit of the stomach, which is called the fundus, is taken around the back of the gullet and wrapped in a 360-degree fashion and stitched back onto itself and fixed onto the gullet. So that creates a valve-like mechanism around the lower end of the gullet. And everything that we try and do with this operation is to recreate the valve at the lower end of the gullet and to create a length of esophagus gullet inside the stomach, which can be pressurized, or in other words, pressure can be applied to it to prevent acid reflux from coming up into the gullet. So going on to the next one. So this is essentially the steps of the operation. You've got the stomach. The floppy bit is at the very top. I don't know whether you can see my pointer, but you take this bit after dissection, pull it behind the back of the stomach. It's called the fundus, and then you wrap it around and stitch it back onto itself and onto the gullet to prevent it from moving back upwards into the chest. And next slide. And again, this is a description of the operation. I want to be as brief as possible because I want you to have the time to ask questions. So we're taking the gastric fundus, wrapping it around the lower end of the gullet and stitching it in place. This means that we are narrowing this area, creating a valve. If the intra-abdominal pressure increases, what it does is it causes this area to pressurize and act as a valve to prevent any acid from flushing up back into the gullet again. So on to the next one. And you can see the X-ray after the operation has been performed. Again, the barium, which is the yellow or the white contrast that you can see on the X-ray on the left-hand side, going through the valve mechanism, which is lower down here. And you can see the diagram of it. Basically, what it does is it pressurizes this area, so it makes it much narrower and prevents any of the acid that's in the stomach lower down from flushing back up into the gullet. We call this area the lower esophageal sphincter, the LES. We increase the pressure as well as the length with this operation. On to the next slide. Well, how effective is the fundoplication? I would say, in my book, it probably gets rid of 80% of your symptoms in 80% of people that have the operation. And we see that even if you do have very mild reflux after this procedure, then it tends to be treated with Gaviscon and Reni. But essentially, what we're doing is we're stopping people from being on long-term acid medication, which is really important, giving you a better quality of life, decreasing your symptoms, and making it easier for you in the long term. Going on to the next one. What are the risks of procedures? Obviously, there's the risk of having surgery, things like bleeding, infection, clots and leg veins going to the lungs, risk of injury to other organs around. But then if we've created a valve at the lower end of the gullet, what happens is the gas that's in the stomach naturally, you burp less, therefore you get more bloated and more flatulent. It can cause an element of dysphagia, which, as Phil described previously, means that when you're eating, things tend to get stuck, or there's a sensation that it tends to get stuck, and it takes longer to go through the valve that we've created. It can cause vomiting in the initial stages. Dumping is not very common. Scarring around this area can obviously lead to entrapping the vagus nerve, which can alter bowel functions, but these are quite rare, risks at less than 1%. Now on to the next slide. So there are a few other things I need to mention. At Benedin, we do a laparoscopic fundoplication, but there are other procedures that you may have heard of that have come into the array of treatments that we have. One of them is called the link system, and that is a ring of magnets that can be inserted surgically around the lower end of the gullet. And what that does is it closes this area. So again, recreates the sphincter mechanism. When you have something to eat or drink, then as you can see on the right-hand side, the food pushes through the magnets. And then as the food goes through, the magnets close again and prevent acid from coming back up into the gullet. It is a new procedure. We don't have long-term data. And of course, we don't know exactly whether this will last for 10, 15, 20 years. On to the next one. Other treatments include endoscopic devices that can recreate the valve mechanism, and especially the angle of His, which is the acute angle between the gullet and the stomach. There are two procedures. One is the transoral incisionless fundoplication, and that creates the valve mechanism by inserting a device in that area. The other is a stretta procedure, where using microwave frequency, basically we almost zap the muscles in that area to strengthen the muscles, create a bit of fibrous tissue and scar tissue around this area to tighten and narrow the lower end of the gullet. Going on to the next slide. So in summary, reflux is very common. There is non-surgical management is initially diet and lifestyle modification followed by medication. Surgery can be required and very effective for symptom control and improving patients' quality of life. We can move on to the next slide. Thank you very much.
Thank you very much, both of you. That was really interesting. So we now go to the question and answer session of our webinar. We have quite a few questions through already, and if you would like to ask a question, please do go ahead and type one using the Q&A icon at the bottom of the screen. Our first question, gentleman says he's a 73-year-old male who's been taking omeprazole for the last year. Because of long-term problems, he's been taking PPIs and would like to try a more natural way of controlling acid reflux. What are your views of decreasing the stomach's pH, i.e. increasing its acidity, as a means of getting the esophageal sphincter to react more normally and naturally? That for you, Dr. Mayhead?
So the question was lowering the pH in the stomach to allow I'm not sure. I mean, generally speaking, I'm not aware that there is any scientific data around the idea of using acids to somehow improve the sphincter sensitivity. It's a weakness in the mechanism that keeps acid in the stomach that results in reflux, and so it's not. I don't think there's much evidence that I'm aware of that makes a difference. The PPIs work by reducing the amount of gastric acid, but also by reducing the amount of gastric secretions, which obviously reduces the amount of contents that will wash up and down into the esophagus. But I don't think lowering the pH is something that would be conventionally seen as an option to manage reflux.
Okay, probably connects to the next question. This person's been taking omeprazole for about 20 years. They asked if there's anything new and better out there that they can look into.
I wish there was. Yes, indeed, I wish there was. I'm not aware that there's any new drugs in the pipeline for reflux or indeed indigestion in general. Obviously, omeprazole has been around since the mid-80s, I think, and ranitidine and the phenolphthalein have been around since the late 70s. The PPIs are, they do work well, but they don't work well in everyone, and they seem to be ubiquitous. A lot of people take them for many different reasons, and a lot of people are left on them long term because they are felt to be safe. But they generally speaking, they should be stopped if there is no reason why you need to be on one. 20 years is a long time, and if it works, then fabulous. But it's obviously the main concern with long-term PPIs is around sort of bone health, but there isn't another or newer anti-acid medication that is going to take over at the moment, as far as I'm aware.
Okay, thank you. Relatively related to that, what types of asthma medicine can affect this?
Well, steroid inhalers can sometimes cause a degree of can cause problems with esophagitis. They can cause steroids themselves can cause gastric irritation, as they can also cause candidiasis, which is unrelated to reflux as such, but it's another form of esophagitis. So it is mainly the steroids that are an issue. Sometimes the other tablet ones that can do it are the aminophylline is the other one. Sorry, it's not often prescribed for or theophylline or aminophylline, but it's a much more old-fashioned asthma medication that is known to cause gastric reflux.
Okay.
It's a related drug compound to coffee, which also causes reflux.
Okay. Is there a dementia risk factor with taking PPIs like omeprazole?
Yes, someone's been reading the press recently. Yes, there has been a little bit of information about this in people's news feeds on their phones. That the data there is an indication that there may be a risk of memory loss with long-term PPI usage. The data is a little bit equivocal in so much as not all studies say the same thing, and the risk isn't huge, but it is nonetheless statistically significant, which obviously from a scientific perspective doesn't necessarily amount to a huge risk, but nonetheless there is some evidence. But the risk relates, I think, to people who have been on antacid. The risk is thought to be related to people who have been on PPIs from a young age into older age, as opposed to people who have been prescribed them later in life. And so if you're recommended them later in life and you need them and they work, then the benefits probably do outweigh the risks. One has to weigh up always has to weigh up what is the alternative to the PPI. Obviously that can be surgery in the right individual, or it can be an alternative, sometimes stopping another drug that's causing reflux, or it can be, or you carry on taking the antacid because your quality of life is better with it than without it.
And is there also a risk of Barrett's? Is that correct?
Indeed, there is a risk with reflux. Absolutely, there is a risk of Barrett's esophagus. It was obviously at the beginning of my presentation, I was talking about that as one of the consequences that can occur with long-term reflux. That you can develop this Barrett's esophagus condition, which has a cancer risk associated with it, and therefore you end up with surveillance endoscopies to over the long term. So yes, reflux is a risk factor for Barrett's indeed.
Okay. Do citrus, I think you covered this, but you might want to just go in a bit more detail. Do citrus fruits and tomatoes cause reflux more than other fruits? They seem to always get heartburn after eating them.
Yes. Simply yes. Yes, they are well known. They're acidic fruits.
All the nice ones. Thank you. Okay. This person says they seem to only have pain on the right-hand side when swallowing, but no other symptoms. That was the question. I guess that's something that they should probably come in for a consultation to find out more.
I would have thought so. Yes.
Yeah.
I don't think one would be unwise to try and make any judgments over Zoom on that one.
Okay. This person has daily reflux, which is made much worse by bloating, which is probably hormonal, as no accompanying bowel symptoms. They are a 43-year-old female, perimenopausal, no heart pain, but shortness of breath and neck symptoms also. Lansoprazole, only partly effective. Is there any hope for resolution of symptoms?
Well, menopause does alter gastrointestinal function overall. Bloating, there's lots of reasons why people bloat, related to obviously hormonal changes, but dietary issues, constipation, and there is another condition called small intestinal bacterial overgrowth, SIBO, which is a condition that's become much more it's a condition that's been looked for a lot more within the medical world, but also as people are people accessing healthcare are much more aware of this as a diagnosis, which can sometimes exacerbate or can feel like it makes reflux worse. And it can be associated with long-term antacid usage, such as PPIs. And so there's possibly a number of things that could be assessed for in this person over and above just not necessarily just making menopause solely responsible.
Okay. I have a question for you now, Mr. Hamida. Does LINX affect a pacemaker?
Well, LINX is a magnetic device and it's also metallic. So we know that it is not indicated with a pacemaker. We shouldn't really be using it with a pacemaker. So that is one of the contraindications. I wouldn't suggest that we can use it. Yeah.
Okay. And how are hiatus hernias detected? Is it through scans? Someone asks.
Well, hiatus hernias can be detected through several tests, really. As mentioned, a barium meal. So if you have some contrast, you swallow it down, we do an X-ray, we can see part of the stomach above the diaphragm. And that in itself is a diagnosis. With a camera, an endoscopy, it's quite easy to see. We go into the stomach, reverse back and look up onto ourselves. And if you see that huge pit around the scope that we saw a picture of earlier, then that is a diagnosis of hiatus hernia. Now, there are two types of hiatus hernias. And to be really honest with you, as surgeons, we don't really worry too much about the two types because they need to be treated, and both of them are treated by the same operation. I would have to say that the one that rolls, where part of the stomach rolls up next to the gullet, and the gullet is in position, the same position, is probably slightly more dangerous because it can lead to a strangulation or an obstruction of the stomach itself. And therefore, we pay a lot more attention to that one and treat it a lot quicker.
Thank you. Going back to the medication side, we have lots of questions here. It's great. Is there any treatment and test for respiratory reflux?
You can do things like manometry. So you can do, so an ENT surgeon will sometimes infer that there is reflux into the larynx by looking in with a small camera into the back of the throat, and you'll see sort of redness or erythema, the redness of the vocal cords. You can do tests like the pH and manometry studies where you can demonstrate that that gastric acid is washing up and down into the esophagus, and obviously ambulatory or 24-hour pH manometry studies would, if they demonstrate acid or in the esophagus overnight when someone is asleep, that can infer that sometimes nocturnal symptoms are related to or nocturnal symptoms or brewing your respiratory symptoms could be related to gastric reflux. So it is often, it's often people who reflux at night time. Often, if they describe that they have asthma at night, but actually perhaps they are refluxing at night. So there are ways of assessing whether or not the gastric contents is washing up into the vocal cords. It's usually done with things like pH and manometry studies.
Thank you. This person has polyps in their stomach related to PPI, they believe. Should they be concerned?
Short answer is no. They are called cystic fundic gland polyps, and they typically occur with PPI usage, omeprazole usage, or lansoprazole usage, but they are not precancerous. There are obviously other polyps in the stomach that are potentially cancerous, and but we're not talking about those. The ones related to antacid medications are very much benign and don't. The only time I've ever seen a problem with one when one has been big enough and it has bled a little bit, but it's been one patient out of many thousands and thousands of endoscopies I've done.
Thank you. Is a fundoplication operation permanent?
So it's designed to be permanent, yes. When we're doing a fundoplication, we're actually trying to do it with non-absorbable stitches. We are actually doing it with non-absorbable stitches. And that is to make sure that it stays there for life. Now, the stitching itself can cause a bit of scarring, which is beneficial because once scar tissue gets holds that area, it stays there for life. One of the things, of course, that can happen is a recurrence, where the whole wrap migrates back up into the chest again, and you get a recurrence of symptoms with another hiatus hernia. And I probably think the incidence of recurrence is anywhere between 2 and 5%. Depending on the type of fundoplication that's been done. But yes, the intention is for it to be a permanent procedure.
And is there any data on their frequency and severity of post-operative complications?
Well, it depends on what post-op complications we're talking about. But if it's things like bleeding and infection, then it's the normal sort of incidence after any procedure. With keyhole surgery, of course, the incidence is much less. We just talked about recurrence rates and wrap migration, and again, that's about 2 to 5%. Things that are more common would be dysphagia, a sense of tightness after you've had a fundoplication, and that's why we have a very regimented protocol after surgery. So for the first week, we're only on liquids. The second week, we start on soft food, and then the third week, we start introducing solids very slowly. And that's why it's really important that obviously people follow the instructions. You won't be able to eat things like steak and bread after you've had a fundoplication. And we must chew our food very well, eat little and often, and just, gradually develop our eating patterns and our diet over a period of time to allow for the edema and the swelling from surgery to settle.
Thank you. How long after an endoscopy and taking of lanzaparole for Barrett's? Would you expect to review and see if there's any progress?
Sometimes Barrett's is sometimes picked up or suspected when someone has their first endoscopy for reflux symptoms, and you look down and you see quite severe esophagitis. So you see there's a lot of inflammation, but you suspect there might be some Barrett's as well. And so in that situation, you might give someone a good dose of antacid. It might be something like 40 milligrams of omeprazole at least a day, if not a little more. And you would rescope them at 8 weeks to see that to reassess the esophagus to see if any Barrett's remains. And you would scope somebody whilst taking their omeprazole or whichever PPI they're on, to see whether or not whether there is indeed Barrett's esophagus underneath all the inflammation. So you'd expect to see healing from esophagitis within weeks. In terms of Barrett's esophagus itself, generally once it is there, it doesn't go away. It can progress and become a longer segment of Barrett's, and you would offer endoscopy depending on how much Barrett's somebody has, or indeed if there are any worrisome features within it. Generally speaking, if it is fairly standard, somewhere between 3 and 5 years, you might offer somebody an endoscopy, but that is really just not to see that it is just to look for surveillance purposes. If there are any worrisome changes, you might scope people at 6 months to see what's happening whilst they're on high dose antacid medication. So Barrett's doesn't go away as such, but you look to see whether it's progressing or it's getting worse, and you do that sort of generally every 3 to 5 years.
Thank you. Why does this person have symptoms that disappear and reappear suddenly, but over months and without any obvious changes in diet? Why could that be?
Well, reflux is a condition that waxes and wanes, and whilst I'd love to know, I think I know it all. There is very often there's a lot of things in medicine that remain unexplained, but we know things like stress, for example, can be a contributing factor sometimes in some people's experience of reflux. Obviously, diet and obviously things like fizzy drinks and eating on the run, eating in a hurry again can cause symptoms to come and go. So there are some reasons obviously that might be relevant to why it's there one day and not another, but it is a condition that does tend to wax and wane, and sometimes we don't necessarily know why.
Is gastritis associated with hiatus hernia, and how do you treat gastritis?
Gastritis, the itis means inflammation. Gastritis obviously means inflammation of the stomach. So it's often treated with the same. There's often some similar risk factors, things like smoking and alcohol and certain foods can cause gastritis, and certain drugs can, such as non-steroidals, Voltarol, ibuprofen, aspirin, and steroids. But it's not necessarily associated with a hiatus hernia. A hiatus hernia is a structural issue that makes your risk of reflux and esophagitis much greater. I hope that makes sense.
It does. I'm sorry, we've still got lots of questions, but we're running out of time, so I'm just going to do one more here. This person has been on PPI therapy for 10 years now. They are 24 years of age, and surgery is being considered. They've had an endoscopy and a 24-hour pH test, and also the Bravo test. They had difficulty swallowing when they had the Bravo capsule. Regarding the surgery of tightening the area, would my swallowing become the same as when I had the Bravo capsule? This is a concern when thinking about the risk factors of the surgery.
So I'm not too sure about the Bravo capsule causing a bit of difficulty in swallowing. It may just be that there was a bit of inflammation at the time that caused this sort of sensation. However, inflammatory reactions will obviously subside over a period of time. And similarly with surgery, the swelling that occurs following surgery will subside, and people will get used to the new way of eating, which is, again, as said before, eating little and often chewing food very well. I think that, to be very honest, and a lot of the questions that I've looked at here are about people who've had heartburn and reflux for a long period of time. and with medication and lifestyle modification, they've come to the end of their tether, and they don't know what else to do. And I think it's really important to say that you need to come and see the specialist, like myself and Phil, to get a diagnosis, to get the test done, and if eligible, to have another option such as surgery to treat it, then that obviously is quite important. It changes the quality of life. It makes things much better. It can reduce reflux completely. There's probably a very small chance that you'll have mild reflux, which can be treated with Gaviscon and Reni. And so I think the quality of life after surgery is much more of a benefit than to stay on long-term PPIs when you're quite young and not seeing a resolution.
Thank you. I'm sorry if we didn't answer all your questions. If you provided your name, we will answer these via email at a later date. So thank you for joining this session. And as a thank you, we're offering 50% off the value of your consultation. We're also offering a callback from our dedicated private patient advisors. You will receive an email with the recording, the treatment information, and also loyalty points from our loyalty scheme. And you can also receive updates on news and future events. We'd be grateful if you could complete the survey at the end of this session, as it helps us shape future events. And if you'd like to discuss or book a consultation, then please do so using the phone number on the screen. You can speak to our private patients team up to 9 p.m. this evening, or between 8 a.m. and 6 p.m. Monday to Friday. Our next webinar is on varicose veins treatment, which you can sign up to via our website. That's with Mr. Aaron Sweeney. So on behalf of our presenters, our expert team at Bendon Hospital, I'd like to say thank you for joining us today, and we hope to hear from you very soon. Thank you and goodbye.
Bye.
Bye.